So welcome to the afternoon report. Sorry for the glitches. Probably towards the end of our academic year, my last afternoon report. So I'll try to keep it very short and simple so that people can go for their academic half day. So let me see. Oh, is it moving? Okay, yeah. So I just want you to, this is a philosophy I kind of align myself with. Beautiful or elegant theory is more likely to be right than a theory that is inelegant, Dr. Gelman. I want everyone to kind of keep this in the back of the mind while we discuss this case. So we have a patient with a chief 33-year-old gentleman with no past medical history on PrEP, presenting with 7 days of jaundice, clay-colored stool, and dark urine with some right-sided abdominal pain. So coming to the HPI, we have a young gentleman on PrEP, Descovy, who is presenting with 7 days of jaundice. There is some right upper quadrant pain, abdominal pain, which is dragging in nature. Some pruritus, clay colored stools, dark colored urine, for which he saw his primary care physician and was sent to the ED immediately. Around 45 days prior to this presentation, he had some sore throat and he started taking his husband's amoxicillin, but stopped it. But later on, he was re-prescribed amoxicillin for strep throat, a total of 10-day course. He had fever and diarrhea during this time, and he took some ibuprofen for the fever, but no Tylenol during the time he had this strep throat. Around 30 days prior to this presentation, patient went to Mexico. He hiked around, also biked in the jungle and visited some underwater caves, but he denies getting any diarrhea or falling sick during that time. Around 10 days prior to this presentation, he went to London. He had an episode of binge drinking, around 6 drinks. And the next day, he started feeling the symptoms of abdominal pain, nausea, vomiting, noticed some jaundice, and thought that the abdominal pain was secondary to drinking, and so didn't do much about it until he came back from London. A day prior to the presentation, he found that his symptoms were still persistent. He was still having nausea, some episodes of vomiting. So he saw his primary care physician, and now he presents to the ED. So does anyone have any questions here before I go to the reviewer system?
Sorry, Subrat, did you say fever or no?
No fever.
Okay.
And the abdominal pain was kind of dragging in nature and not associated with food. He didn't per se complain of loss of appetite, but mentioned that he has not been able to put down food because he just felt nauseous throughout the day.
Alma is asking any rash or lymphadenopathy?
No rash. What is the other question?
Lymphadenopathy?
No. I mean, I will go talk about in the examination, but no lymphadenopathy. Yeah.
Any sick contact?
No sick contact that he could mention. He even for the strep throat, he couldn't give any sick contacts. He said he won't kind of recall being contact with anyone who was sick.
And Mani is asking any herbal meds?
Any sorry, what?
Any herbal meds?
Not on any herbal meds, no.
And any compliance with the PrEP? Is he compliant?
Yeah, he is very compliant with the PrEP. Yes, he has been taking it for the last 2 years.
And Nick is asking if the husband is having similar symptoms or whoever he traveled with to, I guess, London or Mexico.
They're not having similar symptoms. Actually, husband was at the bedside and he was completely fine.
Ariel is asking up to date with vaccinations.
Regarding the vaccination, he did mention that he didn't remember if he had taken the hepatitis vaccinations, but he said that one of the times during one of the primary care visits, his physician did mention that his titers are slightly low and he might consider revaccinating himself, but he was not really sure about which vaccine they were talking about.
So the title of what? Because Anna is also asking about vaccination for hepatitis A or B.
So he did not know which hepatitis they were talking about.
Okay.
He did mention that because especially I think they're considering about vaccination before traveling to Mexico. He did mention that his PCV found that his titers were low, but he was not really sure which hepatitis titers they were talking about.
Okay. And Curtin is asking if he had any weight loss,
No weight loss.
any history of eating food in the street,
Any history of what? Sorry.
eating food in the street.
He mentioned that when he was in Mexico, he did like eat around. Like I didn't specifically ask for street food, but he said he had ceviche and like he was like a bit in. I mean, it's not. I didn't specifically ask for street food, but he mentioned that he did eat raw fish and stuff. Yeah.
Any other questions, guys? No. Okay. Maybe you can continue telling us a little bit more.
So coming to the review system, so there's no weight loss, like I mentioned, no change in appetite, though he mentioned that he feels nauseous throughout the day. Had yellowing of eyes, no cough, no shortness of breath, no chest pain, no palpitations, no symptoms warranting a cardiology consult. So in GI, GU, we have some abdominal pain, which I mentioned is bragging in nature, nausea, vomiting, and dark colored urine. No weakness or seizures, and he did have yellowing of skin. Then coming to some of the longitudinal history, which people are asking, he has no known drug allergies, no past medical or surgical history. His parents have diabetes, but he has no autoimmune history in his family. And socially speaking, he does not smoke, very like occasional drinking, social drinking, no illicit drug use, and he mentioned that he had recent antireceptive intercourse with his husband, no new partners. Medications, he has been on Descovy, been taking it for the last 2 years, very compliant with it, and finasteride for hair loss, for taking for the last 1 year, and he took amoxicillin for around 10 to 12 days during the last time he had stripped throat for around 45 days prior to this presentation, and he was taking some transitional elements and like alkali earth metals like calcium, magnesium, zinc, vitamin C, but no herbal supplements or like herbal tea or anything like that. And travel history, went to Mexico around 30 days ago and to London around a week.
Ariel is asking if he had jaundice in the past.
He had never noticed jaundice in the past. This is the first time he actually, and that's why he got worried that he was getting yellowing of eye, and so he went to the primary care physician.
And I have a question. So you're saying that he only has intercourse with his husband, but he's taking this COVID because it's an open relationship, or like what's the reason for the discovery?
Yeah, I didn't explore it in as much details. I got to see him only once, and his husband was at the bedside. I specifically did not ask why he has been taking Descovy, because that, like you mentioned, he is in monogamous relationship, but I did explore that part.
Because you never trust what your partner's doing.
And Frida is asking, any history of gallstones?
No, he has never had any history of any gallstone, like never been admitted. This first time actually he was coming to the ED.
Okay. Okay, we can move forward.
Okay.
I think.
So going to the vitals and physical examination. So as I mentioned, no fever, blood pressure 134 over 84, breathing fine, saturating well at room air, no tachycardia. On examination, more or less, rest of the system was normal. Soft, non-distended abdomen. There is some tenderness to palpation of the right upper quadrant, and there is hepatomegaly on palpation, and there is dullness on percussion around 3 to 5 centimeters below the coastal margin, but no splenomegaly, and bound sounds were normoactive. No ascites on percussion. And there was no focal neurological deficits, ANO cross 3, and no astraxis or any gait abnormalities. And there was, other than jaundice and bulbar conjunctiva, yellowing of bulbar conjunctiva, there was no rashes, no palmar edema, no scleroderma, and no lymphadenopathy. So we'll come to the problem representation now. So what is the patient, what is the temporal pattern of illness, and what is the clinical syndrome we're looking at? Anyone wants to summarize?
Who wants to try? We can go back in the HPI if you guys need to go and have a look at it. Archana, do you want to try? I'm just gonna call someone that I see.
I can try.
Okay, mom, go for it.
So young gentleman with no pertinent past medical history on PrEP and with a recent travel history and antibiotics, coming with a subacute jaundice and abdominal pain. On physical exam, stable hemodynamics and no stigmata of liver disease.
Great. Yeah, I think you put together a lot of important things, that he's young, he has no history of anything, and that he has many risk factors for liver disease. He had antibiotics, he had recent travel. We don't know his vaccination status. And then the fact that the symptoms are pretty acute. He's saying that it's been 7 days with jaundice, so it's pretty acute that he's coming with. And very important that I think mentioned that he has no chronic stigmata of cirrhosis, because then we need to really differentiate that when we approach that type of patient. So I guess when you guys have a patient like this, and I'm sure you've seen 1,000 people with jaundice that come to the clinic or especially come to the hospital, how do you guys approach that? Okay, so what are you saying? Obstructive jaundice, painful hepatomegaly, and recent history of Mexico travel. Exactly. So this is like something that's screaming to us. What is screaming to us, Bokar? What are you thinking of?
So I'm thinking like this obstructive jaundice, painful tender hepatomegaly, and the recent travel to the Mexico. I'm gonna think something going on which is giving some compressive effects and enlarged liver, like any mass in the liver, or maybe liver abscess, recent history, travel to the Mexico, kind of a picture.
Yeah,
Well, there is
absolutely.
no issue of weight loss. I'm not gonna think about the pancreatic head cancer or something like that. Obstructive jaundice differential first comes in my mind. I don't think so. He has a chronic history of stones or any hemolysis, chronic hemolysis, or stone obstructing that. So with obstructive jaundice and this hepatomegaly, I think I'm gonna think about these lines first.
I agree with you. So yeah, so a way that we always think about it is a obstructive jaundice, but also we can look at the bilirubin. Oh wait, Ariel is asking, did you do a rectal or see a picture of the stool?
No, there was like soft stool. I didn't know hemorrhoids, no internal hemorrhoids, and didn't see any blood.
Yeah, and I mean, I think what you're thinking obstructive because the stool are clay colored and the urine are dark, which it's usually a sign of chronic like obstruction, even though the presence of clay stool is not 100%, sensitive or specific for obstructive jaundice, but definitely you might think of that. And when you see jaundice, which ones are the diagnoses that you can never miss because they can be life-threatening for a patient? What do you guys need to rule out? And sometimes you rule out just from the history and the physical exam, but what are some things that you need to think of right away? Yeah, so acute cholangitis, that's one. And what else? Acute cholangitis in this patient is not febrile, it doesn't look that sick, so maybe it's less likely, but definitely something you need to rule out. What else can be life-threatening in someone that is coming with jaundice, especially something acute?
Acute liver failure.
Exactly. So acute liver failure is the second one. So fulminant hepatitis, exactly. And there's another one that it's not really liver related. Massive hemolysis. Thanks, Anna. So these three things you always need to rule out when you approach someone with jaundice. And sometimes you just see that the patient does not have it. So it's not something you need to work up 100% all the time, but this is the three things you need to think of. And then you go to the next step, like what Carl was saying, trying to think if it might be an obstructive or non-obstructive jaundice. And in that case, you will need some blood work also to help you and some imaging, okay? So I'm sure everyone wants to get the same things. You want to get a CBC, you want to get a comp. Go Subrat, yeah.
So exactly like how Julia was mentioning, and Wokar mentioned that, we have the liver injury, which looks like it is there because given the jaundice and hepatomegaly and the right upper quadrant pain, we look at things like in the broadly in hepatic parenchyma, which involves like it could be like hepatitis from viruses, from drugs, autoimmune hepatitis and other stuff. Hepatic circulation involvements in the form of shock, like shock liver, or you could have hepatic congestion from heart failure. In the biliary tree, like we're mentioning, cholangiocarcinomas or like obstructive causes outside of the liver, like pancreatic carcinoma, which is less likely, but in the bigger differential. And the portal circulation involvement in the form of portal vein thrombosis, sometimes seen in cirrhotic patients, less likely in this particular patient. So is there anything else, any other things that come to mind when we're talking about like a liver injury, which looks like a acute to subacute liver injury? Okay, so going to this like kind of word cloud of different things that could cause hepatitis or liver injury or like a jaundice. And like Julia was mentioning, we need to get some lab works to guide us further because the differential is slightly broad. And so like, what are the different lab works we generally try to do so that it helps us in directing in a particular direction? What are the primary, like the basic lab works that you would order for a patient who is in the ED, has jaundice and gives you this particular history?
I mean, I think we always need accompany these patients with jaundice.
Okay.
And I'm sure everyone agrees that you need to look at the bilirubin and to see a fractionated bilirubin.
So this is like the first labs we obtained. We have a WBC of 4.9 with normal differential, hemoglobin of 14.5, platelets of 309. On the comp, we have majority of the BMP part is fairly normal, other than the ALT is grossly elevated. ALT and ASTs are like in like 4,000, 2,000. The direct bilirubin is 9.7 and total is 12.6. And the ALP is 210 with LDH of 500 and total serum of total protein is 5.9. And the PT, PTT, INR are fairly within normal limits. So the question here is, what kind of a liver injury are we looking at?
Before we go there, Ariel is asking if we had any eosinophils count.
The eosinophils within normal limits, yes. That I didn't put it there, but they were fairly normal, yeah.
Okay, so Fatma and Bakar are saying intrahepatic. What's your way? I mean, I think in this case it's pretty like easy because the ALT and ST are much higher than anything else. But what's your way of kind of differentiating the patterns of liver injury? How do you differentiate? Okay, so ALT, ST, and ALK phos, and you can calculate something called R value. So if you have the ALT of the patient, you divide it by the upper limit of normal of the ALT, and then you take the ALK phos, and you divide it by the upper limit of normal of the ALK phos. And you divide these two numbers that you get from the ALT and from the ALK phos, then you get something called R value. If the R value is 5 or more, you think of hepatocellular pattern. If it's less than 2, it's going to be a cholestatic. If it's between 2 and 5, it's a mixed pattern. Okay. I think right now we have ALT and AST much higher than an ALK phos. So of course you guys are saying correctly hepatocellular. And then I think Subrat was asking, what do you guys think when you see this type of comp in your patient? How you define this patient? So he has liver injury. It's a hepatocellular pattern. It's like a severe liver injuries. These are severe. Actually, it's liver failure. What is this?
Yeah, so liver enzymes more than 10 times upper limit of normal. 3 things come up to my mind: ischemic disease, drug-induced, and viral hepatitis.
Exactly. There's actually an article from Dr. Bro that says that usually when ALT and AST are more than 1,000, these are the 3 main differentials. And if they're more than 5,000, it's usually either DILI or ischemic hepatitis. So these are the things that you think. And I would like to ask you guys, is this acute liver failure? Okay, Fatma, absolutely. I think viral hepatitis is definitely our differential. And Kirtan is asking, do we have coags? Yeah, they're here in the, so INR is 1.2, PTT is 34.6. Man, can you tell me why it's not liver failure? Okay, perfect. So liver failure, you have it when you have severe liver injury. That man said it's when you have ALT and AST usually more than 1,000, so more than 10 times normal. You can have a bilirubin more than 3, but that's not needed for the diagnosis of acute liver injury. It's called acute, which means that the patient cannot have cirrhosis. So you cannot have a chronic liver problem, or at least you can have a liver injury that's been diagnosed within 6 months. So otherwise the patient has a chronic issue, it's not an acute only issue. And that's an acute liver injury. To be failure, then you need to have an INR or more than 1.5, as Eric is saying, and you have to have hepatic encephalopathy. So this is not acute liver failure. Good point. Okay, Subrat, sorry, you can go back and tell us more, or actually ask
So,
us more.
given no, thank you, Julia, for discussing the liver failure versus injury. I think it's a very important thing that we need to know, especially in the ED, to kind of see how acutely we need to involve other faculties and like GI in this whole process. So given this particular kind of hepatocellular injury with severe acute liver injury, what are the different labs we need to draw, and what do you want to do? Do you want to start treating, or is there any other labs you need to draw to help us guide further? We have a very young patient, has a very good insurance. So yeah, the sky is the limit.
Okay, Fatma is saying viral hepatitis, EBV, CMV, HIV as well.
Okay, we'll do that. So these are some more labs. We have haptoglobin of 60 because hemolysis is definitely something that comes to our mind. This is fairly normal number. The Tylenol levels are less than 3. HIV negative, monosport is negative for EBV, CMV is negative. Ferritin is high, probably acute phase reactant. Otherwise, iron panels are normal. The Titan screen is B positive, no antibodies. Factor 8 was done to just get an idea if it's a liver involvement. So if factor 8 is high, factor 8 is actually one of the coagulation factors that is high in liver injury as compared to other ones which are lower. So which is 588, the normal is between 50 to 150. The Coombs test is negative, and this is the hepatitis panel. Hep-A IgM was pending at the time of the admission and through the hospital stay. Hepatitis B surface antibody is low. So in retrospect, I do think that this might be the one that primary care physician was mentioning about, that it's low. Surface antigen is non-reactive, hepatitis C is non-reactive, and Hep E is also non-reactive. Okay, I see that. Sorry,
Eric,
I see that
yeah.
Eric was asking for some more smooth muscle antibodies. Although, okay. We got a Coombs test. It's negative. Oh, sorry. Why we are getting Coombs test? I think there was a consideration that there's some hemolysis going on, so they drew it at the same time. But I'm not really sure why else it was drawn.
I don't know if that was the case, to be honest, but sometimes if you have Wilson disease, you can have a Coombs negative hemolysis, even though I doubt that they were thinking that this person had Wilson disease, but I don't know if that was any correlation. And I don't know, maybe it was drawn when the patient had the jaundice in the broad differentials of maybe hemolysis, but I don't know. If it is saying also HSV. Okay.
I do not think HSV was collected. I don't remember.
And I think you guys brought up very important tests that need to be done. I just wanted to make a point, and I'm going to share with you an article, but specifically for CMV, ABV, and HSV, they can cause acute hepatitis, but usually they cause acute hepatitis for patients that are immunosuppressed or are taking chemotherapy or just had a transplant, for example. So technically, I know that we learned that that's the panel that you should send, but technically, unless you have that specific concern of immunosuppressions in chemo, they should not be really high in your differential for a otherwise healthy person that you're suspecting acute hepatitis. But it's something that you need to think of in case you don't find a diagnosis.
So yes, we did draw some more labs, and I'll go to them. So we did send all the panels that people would generally send, like which one did Eric wanted? Smooth muscle. Yeah, that's negative, I guess, from what I remember. Then centromere was negative. ANA was positive, but it can be positive for multiple things. IgM was IgM total was slightly high. The normal value is up to 230. IgG total was within normal limits. It's 1500 is the normal limits. Slightly low albumin, 3.1. It says 1:80.
1:80. Okay, so it was not.
Yeah, that's a homogeneous pattern. Yeah, that's 1:80. Yeah, for the ANA. So about hemochromatosis, chromatosis in the differential. So what are the differential as of now with all these labs put together? And I have an ultrasound of the liver also, which is mostly saying that it's hypoechoic liver parenchyma with accentuation of the periportal echoes, which clinically correlate with acute hepatitis. So, and no gallbladder involvement. So what is the differential as of now? Did these labs help us kind of narrow down our differential, or?
Okay, so Bakari is saying viral hepatitis at the top, which is definitely correct in his differential. What else are you guys thinking of for this patient that right now is basically everything negative? So idiosyncratic from which medication, man?
I'm not sure, honestly.
Okay.
Maybe I don't know if he took something from his like vitamins or something.
Yeah, I mean, there's tons of medications that can cause DD, so absolutely.
And
I think in this case, liver biopsy will probably, in one of the few cases where you don't know, it may be, if we don't have a right diagnosis.
Yeah, especially, I mean, he's young, the LTN is still pretty high, so if you do not have a diagnosis, that would be necessary. Or you think could also be acute alcoholic hepatitis since episode started after binge drinking. Yes, LFTs are really high to be alcoholic hepatitis, but that's also in the differential, even though maybe lower. And Vakar is bringing up a good point. The hepatitis A is still pending. Yes, we don't really know.
Okay. Yeah, exactly. Like as Man and Vakar was mentioning, like viral hepatitis, DILI, or it could be something along those lines. And so what do we do? Because this was a patient who was in the ED in the evening. So what should be the next step in this particular situation?
Are we guys consulting hepatology? Are we transferring this patient to a transplant center? Are we waiting for labs to come back? Are we starting any medications or stopping any medications? Okay, so Wakar wants to see if the labs are coming back. Is anyone consulting GI? Okay, so Frida thinks that he doesn't need to transfer because he has no liver failure.
But I think we need to alert them to see, because he may be precipitating, he may be like getting worse. If things got worse, he may have to like start an acetylcysteine, do stuff for potential prevention of liver failure.
Yeah, I think this guy is pretty young and his LFTs were 4,000 or something. So that can be concerning. So even if he's not on acute failure right now, I think we need to be kind of cautious. Exactly.
Yeah, agreed. So just we'll go to the hospital course. So we admitted the patient to the floor for management of acute liver injury without failure because INR is not greater than 1.5, no encephalopathy. And the NA was 21, which Man, correct me. I think it's high. It's not extremely high, but it's still pretty high. I think greater than 26 is something where you are considering like liver transplant emergently. He was started on the NAC protocol. We consulted GI. We started on the acetylcysteine protocol, 21-hour IV protocol. Given there is some, even though the acetaminophen level was low, but there is some evidence of NAC being helpful in non-Tylenol related toxicities. The patient was transferred to MSH because there was earlier bed availability. This was during this times when all the EDs were full and everything. And the GI team continued with the working hypothesis of idiosyncratic DILI. NAC was continued. Amoxicillin was considered as a culprit. And it was put as one of the allergies on his list. And the PrEP was restarted because it was thought that Descovich in general does not cause as much of DILI. The patient's elliptic continued to improve slowly, and the right upper quadrant when resolved, his nausea and vomiting improved, and he could start. He tolerated oral feeds, and he was discharged on the 4th day with the diagnosis of DILI. His liver labs were like in thousands, like 1,200 or something when he was discharged, and with the liver clinic follow-up scheduled. So this was like the hospital course. And is there any questions regarding the hospital course or the case till now?
Does like really increases the liver span? I don't know. It causes the hepatomegaly and hepatitis.
Yeah, I think coming to the hepatomegaly part, actually, so it's actually also my fault. I did not measure the liver span on percussion. Normally, you should percuss above the margin and below the margin to measure it. I just percussed below the margin, and it might be that he had 3 centimeter below the coastal margin, but the upper boundary might have been still lower. So the total span might not have been too big, because on the ultrasound, it said that the liver span was slightly increased, not like, they didn't comment on the number actually. I was trying to look at the ultrasound. They didn't comment about the liver span. It could be that there's some hepatitis, but like hepatomegaly, but might not be as gross. So, anyone has any other comments?
I guess my only comment is that a lot of medications can cause DILI, and I'm just gonna send you this link, which is basically the NCBI. Like you can just put any medication and see if it causes any type of DILI and what type of pattern of injury should cause. So that's something you can use in your clinical practice when you're thinking that there may be hepatotoxicity from drugs.
So I think this is a very cool case, because like as Walker was mentioning, that there are some labs that are still pending. So actually,
so
on the 10th day,
what is can I ask you one more question? What is the rationale for using N-acetylcysteine in this case? Like, okay, we use in acetaminophen toxicity causing the liver injury. We know the acetaminophen levels were low.
Yeah, I agree. I had this discussion with my intern, and I personally was still thinking about, like, let's wait for the labs, but there is some evidence even in non-acetaminophen toxicities that you can use N-acetylcysteine for DILIs. It's hepatoprotective. I think, I mean, I do not know if it's RCTs. I never tried to go and check it, but I spoke with the GI fellow and the attendings, and they were fairly convinced that it is helpful, doesn't have too much of downside. So that's why we went forward with it. Yeah. So yeah, like, so this is interesting, because I pretty strongly believe that it could be hepatitis A, given that the timeline was kind of matching up. Amoxicillin generally causes cholestatic kind of hepatic injury as compared to hepatocellular. And it somehow took a long time for the hepatitis A to come back. They sent it thrice. We sent it twice at MSH. They sent it one more time, and somehow it came back positive after 10 odd days. So thankfully, the patient followed up with the liver clinic, and they changed the diagnosis to acute hepatitis A infection, had both IgM and IgG positive. He's supposed to follow up in a few months to just see that the trajectory is in the right direction. But I see that he's still, amoxicillin is still listed as one of the allergies. I am not really sure if it should still be an allergy on his list. But this is what the final last visit I could check, and he still had amoxicillin as one of the allergies.
So I do have to say that's a complete failure of whoever prescribed him Descovy, because one of the things you're supposed to do when you prescribe PrEP to someone is do a whole STI panel, including making sure that they're immune to both hepatitis A and hepatitis B, right? Because that's something that men who have sex with men are at high risk for. So whoever prescribed him the Descovy really failed this person by not making sure he was immunized against Hep A.
I agree. I think from what I understood, his PCP did probably try to get him a vaccination, but he denied or something. I'm not really sure about that part, but of course you should always get them immunized and see that the titers are there when you're starting PrEP. So, okay, so we're going to acute liver injury. I'll keep it very short. So normally the approach about liver transaminases is, of course, perform a good history and physical, review any hepatotoxic medications and alcohol use like brought out by everyone, and consider stopping any of the medications which could potentially cause liver injury. Assess risk for viral hepatitis, which is really important, especially because in the US, we do not see as much of viral hepatitis, but people who are traveling outside of the US could get it and contract viral hepatitis and present to our hospitals. And also assess for NAFLD. Consider any muscle disorder, there's isolated EST elevation. And then based on how high the elevation in the ASTs and the ALTs are, we divided them into 3 categories. Less than 5, we're looking more towards like it could be a hemolysis or something like that, do an abdominal ultrasound, get the viral panels, and ceruloplasmin for Wilson disease for patients less than 40. And for people whose ASTs and ALTs are within 15 times of the upper limit, like 5 to 10 times of the upper limit, we can consider other etiologies like autoimmune hepatitis, for which you can do a smooth muscle, or you can consider also doing like monospot and other tests for any kind of viral hepatitis. But today's topic of discussion is not less than 15. We're talking mostly about liver enzyme elevation greater than 15 times or greater than 10 to 15 times. And that's what is our topic of discussion about severe acute liver injury. And like how Man brought out that, even with the liver injury, if you do not have signs of hepatic encephalopathy or liver failure in the form of INR greater than 1.5, it's still liver injury, but not failure. But we have to keep a very close eye on them because they can move into failure pretty quickly. Like I was mentioning, the top causes are ischemic hepatitis from shock liver, and you could have drugs and herbal supplements which could cause DILI and viral hepatitis. Going to the distribution of this is a very important slide. This is slightly dated in the sense this is from 2014, I guess. But I couldn't find a slide which represented different causes of acute liver injury based on like distribution, based on like where the person is coming from. We see that in like South Asian countries, hepatitis E and hepatitis A and hepatitis viruses are something that causes a lot of liver injury. Medications are not a major cause, whereas in United States and like on the west of Atlantic, we see that acetaminophen causes around 40% of DILI, and other drugs cause around 10 to 13% of drug-induced liver injuries and acute liver failure. Whereas hepatitis A and E, they cause like a minority of like around 10% of total causes of acute liver injury. This is really important because a lot of times we have been taught that DILI is like one of the primary causes of liver failure or liver injury. But we have to keep it in mind that the majority of them is caused from Tylenol. And if you take out Tylenol, we need to rule out other causes too, because the rest of the drugs cause only 10% of drug-induced liver injury. Then clinical findings, slightly busy slide, but the thing I wanted to bring out is that acute liver injury and liver failure are are something that is more in critical care domain, because there's a lot of things happening. It's like almost like sepsis. It's just not the liver. It can affect your brain in the form of hepatic encephalopathy. It is something that we need to be very careful about. Can cause hair output, heart failure. It sometimes involves the kidney with AKIs, and which can lead to CKD in future. And it can also produce a systemic inflammatory response and ARDS. So just to keep in mind that even though the patient might look okay in the beginning, but we have to keep a very close eye because they can deteriorate pretty quickly. Then the management, again, just to kind of bring home the idea that we have to involve the liver team pretty early, have to keep a close eye on the cardiovascular system, because most of the times these patients do come with like some hypovolemia secondary to nausea or vomiting, and also like poor PO intake. Also, there's a distributive shock that's going on. So sometimes you have to replete the volume, and if they're still not being managed with just volume repletion, you need to start vasopressors and inotropic support, and need ICU kind of a setup to help with that. One other thing we always keep an eye on is like metabolic and renal disorders, especially hypoglycemia, because a lot of gluconeogenesis happens to the liver, and in liver failure, you do not have that. So you have to keep a close eye on that. And coming back to the idea about cerebral edema and encephalopathy, we'll talk about it a bit in details in the management part of it. But the idea is that the cerebral edema portends pretty bad outcomes for patients who have liver injury and liver failure. So the things to keep in mind is like we need to have an early recognition of decompensation and involve the GI and liver team a bit early. Acetaminophen poisoning, NAC administration is crucial, and the timing of the administration is very important. There is some evidence of using NAC in non-acetaminophen related DILI. I do not know if viral hepatitis has any evidence. I haven't found it, and actually I didn't try to dig up any RCTs or anything on that. But it's a very benign thing to give, and I think a lot of people favor giving NAC when there's such high liver enzymes. Poor PO intake and vasodilation can manifest in the form of hypovolemia. So intravascular volume repletion should be initially tried, and you might need norepinephrine and titratable vasopressin support to help with the hemodynamics. Encephalopathy and cerebral edema portends poor outcome, and the idea is to prevent onset of hepatic encephalopathy and to limit its severity and prevent any kind of cerebral edema. The rate of ammonia increase is what determines the severity of cerebral edema. So keeping a close eye on that is very important. There is no clear winners. Once hepatic encephalopathy sets in, there is like no clear winners, as in trying to do hypothermia or doing hyperosmolar therapy. There have been some trials, and they're trying to look at which has better outcomes, but the consensus is that try to give some hyperosmolar therapy in the form of 3% sodium chloride and hypothermia to decrease the extent of cerebral edema. The idea is to catch patients for liver transplant before they are too sick to get the transplant, because by virtue of them being hemodynamically unstable, a lot of people do not do really well when they get the liver transplant if they have gone hepatic encephalopathy. And there are like multiple risk scoring systems, like MELD-NA is one. We have King's College criteria, which is used for acetaminophen toxicity. We have the Clichy criteria for viral hepatitis and Japanese criteria for acute liver failure. A majority of them have INR and hepatic encephalopathy as one of the factors, and the level of bilirubin as one of the factors to determine if they need a liver transplant. Over in the US, we use MELD-NA for, it's been used by the UNOS database to kind of risk stratify and to allocate liver to all the liver transplant patients on the list. And some other therapies have been tried, like hepatocyte transplantation. There have been some success in mouse models, but I do not know if it's been tried here in Sinai. And there's some extracorporeal liver assist devices, but they have been very mixed results. Some of them have shown to decrease hepatic encephalopathy, but not much of mortality studies have been done. So I think that's the end. I just wanted to come back to this quote by Professor Moritz Gelman, who is a Nobel laureate from Columbia, I guess, Columbia University. He says that what is especially striking and remarkable is that in fundamental physics, a beautiful or elegant theory is more likely to be right than a theory that is inelegant. And I think that is just not true for fundamental physics. A lot of the times when something aligns together and like a lot of things are coming together to explain a particular theory or like a particular diagnosis, it probably could be correct. I think this is the end of the presentation. Do you have any questions?
Thank you, Subrat. That was great. So first of all, thank you, Dr. Andrei, for sharing the Ryan prep template so that you can take a look for Ryan centers. And then another thing that Subrat and I were talking about when we were discussing the case is that we saw that this patient had very huge workup sent out right away off the bat, like autoimmune, like a lot of rare disease workup was sent, which I think sometimes it makes sense, especially because it's a young patient with very high LFTs and you're worried that they can go into liver failure. But this is like an article from the Things We Do for No Reason. And actually, technically, especially when you have such high LFTs, you don't really need to jump and do such a long workup right away, because as Man was saying earlier, most of the times you have as a differential either viral hepatitis, some drug causing DILI, or some ischemic kind of shock liver situation. So even if you find that the cerebroplasmin, for example, is low, that's not really going to help the patient in that moment. It's not going to help the outcome. And there's a lot of high and false positives for some of these diseases. So it's not something that you should jump to look at right away, because it's not really just going to make the hospitalization be more costly and like increase the cost of care, but it's not going to really improve the outcomes or improve the patient's therapy, because in the end, you're going to do the same things, which is supporting the patient, calling GI, maybe go to a transplant center if needed. And that's not going to change anything right away. So that's something we discussed with Subrat. Let's say that the patient didn't have a lot of money or was not on any type of insurance. But otherwise, that was great, Subrat. Thank you so much.